Thank you, Sergio. Let's move on now promptly to the next and final panel of the morning, Ending Pediatric AIDS, Translating Hope into Reality. The moderator is Charles Lyons, President and Chief Executive Officer for the Elizabeth Glaser Pediatric AIDS Foundation.
Good afternoon, everyone. Conscious of the time, although we're actually doing quite well. We're only about 5 minutes behind. The format for this panel, I will be very, very brief. We've got about a 2.5 minute video that I think frames the topic very well, and then I'm going to call up the panelists, and I'm going to put a couple of questions to them that are germane relative to the topic, and presuming that we have a little bit of time, I'd also very much hope that there were questions from the audience. My name is Chip Lyons. I'm President and CEO of the Elizabeth Glaser Pediatric AIDS Foundation. My and my colleagues' perspectives come from an implementing partner and operating foundation. Regrettably not an endowed foundation, but an operating foundation. Working in 14 countries, we support about 7,000 public sites through ministries of health in those countries, and combine that with both advocacy and research work in the service of a mission to end AIDS in children. So I want to thank IPAC for inviting me to moderate this panel. This audience knows very well the enormous gap, the huge challenge, the inadequacy of our efforts to date in terms of treatment access for children. I think often of the sort of cognitive dissonance that we all have to face, the aspirations against the realities, the hope versus the hype, as Wafa mentioned it. And so you can be pessimistic, you can be optimistic, and I think in turns we may be both. There is an enormous gap. We have underserved kids. We've left kids behind. Our efforts have been inadequate. There's not been enough focus. There's not been enough coordination to really get at what the problems are. It's not a willful disinterest in children. It's the complexity and the challenge, particularly in terms of the cascade and the follow-up and the loss to follow-up sort of challenges. That said, on the reality is difficult side of things, the last several years have seen remarkable improvements, focus, energy, thinking, and so on, and the panelists represent just a part of that collective of thinking and commitment to do far better by kids, and in turn their families, their mothers and their fathers, than we've done so far. That's our intention. We can touch on where we are in terms of the global plan to virtually eliminate pediatric AIDS, the recent announcement about accelerating treatment for children that Ambassador Birx and Pete McDermott can speak to, the work by the Medicine Patent Pool in terms of pediatric formulations, the exciting work from Unitaid on bringing new technology online. There's a lot moving on the optimistic side of things. But these things have to converge. They have to converge quickly. They are consistent with Ambassador Birx's, I very much like right place, right stuff, right time. When it comes to pediatrics, we're very much overdue in applying the right things in the right places. And I think our panelists will be able to speak to those issues. So if folks could turn on start the video for 2.5 minutes.
Over 500 children will die of AIDS today. For these children, treatment is out of reach. And for the 700 who are infected with HIV every day, there is no time to waste. Without treatment, half will die by age 2. The majority will die by the age of 5. Yet, nearly 2 million children are in need of treatment. And adult access to treatment outpaces that of children. So why is our most vulnerable population the least likely to receive treatment? Most babies born to HIV-positive mothers are never even tested, and the children who are tested still may not get treatment. Clinics are too far from home. Stigma keeps caregivers from bringing their children in for testing and treatment. Too many healthcare workers aren't trained to treat young people with HIV. There aren't enough HIV medicines developed for a child's needs. Treatments can be complicated, requiring pills and liquids that can be hard to swallow and taste bad, and caregivers need support to manage it all. The results of all this? We are losing too many children to HIV. This can change. To reach an AIDS-free generation, we need to deliver HIV testing and treatment closer to where children live. Develop more medicines specifically for them. Train caregivers and healthcare workers to identify and treat HIV-positive children. Build a community support system to keep children healthy. And children need to be a political priority to make all of this happen. HIV treatment is a child's right and must be a global priority until no child has HIV and no child dies of AIDS.
So if I could call up the panelists, and you may be following the program. I'm going to add a panelist. She has spontaneously, graciously agreed to join us, the Honorable Minister of Health from Swaziland, if you would join us. Ambassador Birks, Badara Sam from UNAIDS. Pete McDermott, please come up from the Children's Investment Fund Foundation, also known as CIF. Julie's McCullough from Unitaid, who will be representing Philippe, and Anya Giphart, my colleague from the Elizabeth Glaser Pediatric AIDS Foundation. And I'm going to start with, as he's moving towards his chair, and with respect to each of the speakers, I assume most or all of you know who they are, or you can find out if you don't know as much as you want to, but I'm going to dispense with the bios and the background. Badara, from a UNAIDS perspective, Michel has spoken, made reference. I was trying to count how many times this morning he said 90, 90, 90, and I think we were getting close to 90. But nonetheless, those I think have been laid out, but there are also the 90-90-90 targets in relation to kids and pediatrics. Why is it important to have a separate subset? What's the intention of UNAIDS in setting those targets? How is that going to help us? And sorry to do this to you, but you have about 4 or 5 minutes only.
I'll take 3. First of all, thank you very much. I'm standing here on behalf of Michelle, who has to go back, and thank you for inviting us to be part of the panel. I think, of course, Michelle mentioned the 90-90-90 target, and beside the fact that today everybody knows that target drive progress, when we set the 90-90 target, we wanted to take advantage to do some fixes on the way we set targets. And I will mention 3 of fixes that we did in putting 90-90-90 together. The first one is to move from our traditional way of setting target, which was to put numbers. We wanted 3 million people on treatment by 3 million by 25. We wanted 15 by 15. We want 20 by 20, to a different way, which is basically moving from a number to a quality of treatment, basic from a number to cascade, because we were up to now very content to put X number of people on treatment, but down the line we realized that we were losing many of them, so quality was important. The second fix we made was to move from just giving treatment to people for the sake of, which is still very, very good, to avoid death, but here to add something else, which is we give treatment to avoid death, but also we give treatment to reduce transmission. So treatment was there for reduce mortality, but also for prevention. And the third fix that we wanted to make was about equity, and that's where maybe we can start talking about pediatric. If we, we have been always celebrating that we reach 3 by 5. Later, we'll be reaching 15 by 15. We'll be having more than 20 by 20. And we were all very happy with the number. But what we failed to do is to go and be more granular on what was behind the number. And if we become granular about what was behind the number, we'll realize that there were certain geographic areas that were more served than others, that there was certain population that were more served than others. And that's where we can see, if we look at the 14 million people on treatment at the moment, we'll realize that pediatric treatment is not as good as adult treatment. So it's only by having this type of approach that look at equity that we can see that. So those three fixes, if you look at it, of course, one that is very, that talk to pediatric treatment is equity, and the other one is the second fix that we did, which is to move from death to death and new infection. And if you look at 1990, in that sense, you might wish to say that this may not make sense for pediatric treatment. Why? Because children are not transmitters. If we give treatment to children today, it's to save their lives. It's not to reduce transmission of HIV. So I think we need to be driven by other values, that just not about transmission. We should be driven by a moral imperative that we need to have. So can we do it? Can we have 90, 90, 90 as you ask for? I think so, just by looking at the numbers and thinking a little bit. If we look at the numbers, of course, we can see that pediatric treatment is, the coverage is not very, very high in West Africa or in Southern Africa, but it's high actually in Latin America and the Caribbean, or even in Eastern Europe. So if it is possible to have high coverage in Latin America, we should be able, there must be a recipe to make it high in Southern Africa. And then, how should we do it? I think there are three areas that we need to take into consideration. One is a political one, political advocacy. Here we have people who are very content talking to each other one meeting after one meeting. We know that pediatric treatment is a big issue. But get out of this room and talk to politicians, you will be surprised to see how little they know. But by the time we raise awareness, you will see how they will be very, very sensitized and sensitive to pediatric treatment. So I think one fundamental thing that we need to do is to make sure that we invade the political arena, as you say in your videos, on the pediatric message. Two, delivery systems. I think our delivery system needs some real fixes because they are not adapted. And we do not have time to talk about it. I'm sure others will talk about that. And of course, we can have the best political will, we can have the best delivery system, unless we put real money on the table, we're not there. And in that context, we just want, as on behalf of UNAIDS, to applaud PEPFAR and see for the initiative that they just launched in favor of pediatric treatment. Thank you.
Thank you very much, Badar. I'd like the next question to go to Ambassador Birks. Debbie, you were the quiet leader behind a very, very important announcement in early August in Washington during the Summit of African Leaders. And I hope and assume everyone is aware of that, but could you please just characterize what that announcement is in terms of children on treatment? Why now? You're very big on right things, right places, right time, and so you would have done an enormous amount of thinking about why that issue, why now, and where you see it going.
So thank you, and I just want to take this moment to acknowledge EGPAF, because a lot of, many of you know I only am in this job 5 months, and shortly after I got the position, EGPAF held a forum specifically highlighting this on the Hill, on our Parliament, and really showed this very compelling film. And I went back thinking, well, we all have to do something. We have to do something together, and we have to figure this out. And the difficulty with the children issue has been that it's really a humanitarian issue. Treating children under 5 does not directly impact the epidemic in that moment. So it has to be clear that this is an absolute need-based argument to really address one of the largest killers of children under 5. Then we did an analysis as challenged by our administrator, USAID, Rajit Shah, who said, are they in the same place? And again, it was an EggPath sponsored forum that really got us thinking about, is there a way that we should be looking at under 5 survival differently? And so we went through all of the high burden countries and matched where the under 5 survival was matched with highest HIV prevalence and presumably due very much to the high HIV prevalence. And then we knew what our funding constraints were, and we had quiet talks with some individuals that we knew were also very devoted to children, and it became then the ability to actually double the number of children that we have on treatment in these high-burden countries in a focused way to really respond to this huge gap. We do think it will also impact stigma and discrimination because we believe that communities will have to embrace families with HIV and increase that awareness for community support. So we're excited about it. We're excited about doubling the number of individuals just within a 24-month period. We think setting high targets is important. It also makes it a lot of pressure on us, but I think together and with cooperation of the countries, we'll have the ability to do this.
I've been asked why you took the time to involve another partner in the announcement. I think there's some fairly logical answers to that. But there is the notion you can go faster if you take it on yourself. You're PEPFAR, you're big, you're strong, and so on. Why did you commit to working with one or more partners in making this announcement and in funding it and in leading it?
So this is our first partner, and the reason it was important to me personally is because we all know SIF's reputation. I'm sure you all know SIF's reputation. They are very, very demanding for data and performance. And I think it's said to all of the PEPFAR family that SIF also believes that PEPFAR is taking on an expanded dedication to accountability and data and making our work more transparent. And so it really, to me, it also really endorsed what PEPFAR was trying to do on the data side. It also is very important to the American people in our particular financial times to show that we're leveraging what we call public resources with private resources, much like the Global Fund has done and gotten private foundations to fund the Global Fund as well as governments. And so I think it shows where PEPFAR is going with its transparency, but also shows the American people that we're trying to leverage every resource that we have.
Thank you, Debbie. I'm going to ask Pete to comment, and then Julisse, and then Anya, and then having given the Honorable Minister time to hear from those other perspectives, I will ask you then to go last, just from the point of view of Swaziland. How is this germane? How is it going to help you address pediatrics in Swaziland? But since we didn't, having you on the panel was a spontaneous move, I wanted to let you know what the sequence is to give you a chance when we finish with the other speakers. Pete, I think everyone does know it's in your name, and a number of folks in the audience have worked with or near SIF. They know what your commitment is to kids in a variety of areas. You have funded a number of programs related to HIV and AIDS. Why this? Why now? And how optimistic or hopeful are you that the goals that have been set out are achievable as opposed to aspirational?
Yeah. Thanks, Chip. Yeah, just to build on your comments and then Ambassador Burke's, we've had a history of about 10 years in children and HIV/AIDS, orphans and vulnerable children, then pediatric AIDS treatment, funding the Clinton Foundation on the drugs and market access and generics. And then clearly a lot of work over the last 5 years on preventing infections and the Global Elimination Plan and at PMTCT, including with some stellar work with the government of Zimbabwe and EggPath in there and other works. But But what we found is that notwithstanding what we think has been one of the biggest success stories to date in HIV/AIDS, which is the progress we've made on the elimination between parent and children, we're worried that that is beginning to falter and we need to put more efforts into it. But we're also worried by what we call the leaky cascade. So we've actually re-entered the pediatric space. Children are being left behind. That was never the intention. No matter how successful the elimination agenda is, we still have a ballooning population of children infected with HIV/AIDS, and they're not getting the services. The mortality and the excess mortality, which is absolutely preventable, is now becoming a threat to the global child survival agenda. And more importantly, or as importantly, the increased maternal mortality is also not good for women, but it's also not good for children because the correlation between poor outcomes for children. Whether you measure this in terms of access to testing, whether you measure it in terms of the initiation of treatment, whether you work on adherence, at every stage of the cascade, children are being left behind, forgotten, or not considered in the first place. So why now? Now because A, the visibility of the issue is there. Two, we actually have the solutions. We know with B+, and we know with the success of the elimination plan in part, we are reaching adults, and we're reaching women, and we're reaching pregnant women. What we're not doing, though, is tracking those women and their children together. We almost have two different streams of work. So that's one issue. The second issue is we've also, because of our success, made things more complicated. We've pushed infection out actually through the breastfeeding. That creates different challenges. But we can solve this. And the issue is, why are we doing it now? One is because clearly we have good leadership. Two, we can reprioritize. Three, with CIF and PEPFAR resources, we can make a quantum different, transformational now rather than incremental. And we have publicly set a goal which is not only aspirational, it's going to be bloody difficult to achieve, but we also want to hold ourselves publicly accountable for it. And CIF is absolutely delighted because I think the issue also is by using the data that we have, by getting better data, we can target resources. And part of the issue here is about stopping the leaky cascade, applying resources more logically and rationally, and actually more effectively so that we can have a better mortality and care and quality care outcome for children.
Thank you very much, Pete. A question to Jalise. Again, the audience is very familiar with Unitaid, the commodity work, the innovations, the investments, crucial in a number of respects for HIV and AIDS. You recently announced the Pediatric HIV Treatment Initiative. Same basic question. What is it? Why now? And what do you expect to achieve with it?
Thank you, Chip. So, like CIF, we've always also been involved in pediatrics since the start, which was in 2006. And our first major achievement, maybe with Unitaid and with the Clinton Foundation, with CIF, the same project, was the first fixed-dose combination for children, which really revolutionized treatment and really suddenly brought medicine that was just once in the morning, once in the evening, from 16 syrups a day. And also, further to that, it also brought the prices down. So we've always been, Unitaid has always been committed to pediatric medicines. And another area, as you know, is we're very, very interested in the pipeline of medicines and innovation. So last year, WHO brought out its treatment guidelines for pediatric treatments. And when we look at that, we can see a number of shortcomings within what is being proposed. And the idea of this initiative in particular is to map out what those shortcomings are. This is a practical group. We're not an advocacy group. This is a practical group to actually look at what those treatments are and how can we get those treatments better formulated and onto the market as soon as possible. So the group is just set up now. It's still open. It's a working group. We're inviting anyone who have interest in this area to join the working group with us, and it's being led at the moment by the Medicines Patent Pool. The idea for Unitaid is once we have overcome these hurdles, we can actually put these into practical projects that we can then support to get those medicines out there faster.
Are you prepared to talk about point-of-care work and diagnostic work? You've done some things with CHI and with UNICEF, I believe, which is consistent with your new technology and innovations. It's pertinent to pediatrics. Is there?
Absolutely. Now, as I don't know if, as you know, diagnostics, it's a decade of the diagnostics, as we call it, and already we have already invested nearly 200 million, actually, in point-of-care diagnostic technology in HIV, TB, and malaria. Now, why point-of-care diagnostics, and what do we know so far? So to date, we've heavily invested with CHI UNICEF in, actually at this stage, it's viral load CD4, in particular CD4. And we've already seen this huge impact of having point-of-care CD4. And Ambassador, in your slide, you showed Tanzania and you showed Mbeya. We were recently in Mbeya, actually, with Kenley. And we were in a hospital near, where were we? Kiela, down in the south near the lake. And this is a hospital that has 3,500 patients on their book and absolutely no laboratory capacity whatsoever. But what they had access to, 2 weeks, every 3 months, was this mobile unit that came into the district and in one day could diagnose people with HIV, give them a CD4 count, and also do a TB test if needed. And in one day, they had everything they needed to actually go into the hospital and start treatment. Now, talking with them, this could actually take, in a good facility, maybe 1 month, but it could take 6 months, or it could be never. So suddenly, by bringing point-of-care technology to a hospital like that, we're able to much faster get people on treatment, and so we avoid all the loss to follow-up and everything else. So now we're arriving, what is the problem with children? Well, with children we've seen maybe there's 39% access to PCR diagnostics, but that's access. What about coming back to get those results? And we've spoken about it with EGPAF. Mothers aren't coming back to get it. There's stigma, there are problems. What if we could get these children on the same day, give them their HIV diagnosis and know immediately whether to start treatment or not? How much good could we do there? So for us, point-of-care diagnostics for EID is absolutely essential, and we are really hoping, and we're looking to you very strongly now for proposals so that we can actually push forward in that area in the next year.
Thank you very much. Anya. Anya is Head of Medical and Scientific Affairs at EGPAF. As I said in my opening comments, I'd like to think that the tremendous lag for kids isn't out of a willful disregard for kids. It's a reflection more of complexity. We do need to get much better results out of the PMTCT cascade. This is a simplistic question and a hard question at the same time. So what do we do differently? We do have a lot of tools. We think we know where to apply those tools, so right stuff, right place, right time. But obviously that's not been adequate. So in your perfect world, what do we do differently, 3, 4, 5 things?
Yes, thank you, Chip. I think we first need to start, and that's been discussed a lot this morning already, knowing the epidemic in certain geographical areas, knowing how many children are infected in that area, or at the minimum having the estimates. So we need to look at the prevalence, the PMTCT coverage, all these type of things to really understand what is actually the problem in a certain geographical area. And we need to work closely with countries to do that. We need to go away from the targets that we used to have for children, which was just a percentage of those put on treatment needs to be children. But that clearly doesn't identify the gap that exists. So really knowing the epidemic, setting clear targets, knowing what we need to do is number one. Then secondly, identifying the children. And I think also that was mentioned earlier by Pete. Depending on how the PMTCT program works, you have children who are under 2 who are infected, or mostly children who are over 2 who are infected. Making sure that the cascade, the leaky cascades, is addressed. Testing only at 6 weeks is no longer sufficient because, again, with a good working PMTCT program, you won't find many children there, but going through the breastfeeding period, we need to end the testing all that way. For the older children, we need to expand the provider-initiated testing and counseling in those places where the sick children are, in the TB wards, in the inpatient children's ward, and also in the adult clinics, actually making sure that every adult that comes to a clinic asking, are their children infected, can they bring them? So really number 2 is identifying the children much better. Number 3, I would say, is continuing to work on the capacity of the healthcare workers to actually put children on treatment. That's still a big challenge. Even those who are trained often don't feel comfortable enough putting especially small children on treatment, so looking at mentorship. Also looking at task shifting in some of the countries. In those countries where it's still only medical doctors who can put children on treatment, that's not going to be sufficient. So really strengthening the healthcare force to put children on treatment is necessary. Number 4, I would say, is looking at the community and involving the community. We've heard a lot about that this morning as well, both in terms of demand creation. A lot of parents still think that it doesn't make any sense to put a child on treatment because it's going to die anyway. Helping with track and trace when those mothers and children don't come back to the clinic. And also having lay counselors to help with adherence. It's not easy to put children on treatment, so having somebody who you can talk to when you have difficulties providing medicines to your sick child is very important. And then number 5, I would say, continuing to look at our data. We need to evaluate how we're doing. We do know what to do, but I think we often have still difficulties how to deliver what we need to do properly. And really documenting those models that work, those models that don't work, and a very quick dissemination so that the whole community can learn fast and scale up fast.
Thank you, Anja. I'd like to turn to you, Honorable Minister. Just in general, we didn't prepare questions in advance for you. Swaziland has received a lot of positive remarks over sort of the last year in how you've thought about pediatrics, and I think have more kids on ARVs than many other countries as a percentage. But where does this fit in your weekly or monthly set of responsibilities? You think about pediatrics. Do you feel like you're on the right track? Are there adjustments that you feel that that need to be made? And are you hearing anything from the other panelists that would be useful to you in trying to advance this agenda in Swaziland?
Thank you very much, Chair. One can also appreciate the work that is done by all the partners that are pushing the agenda of HIV and AIDS, and especially for treatment. Maybe just to share as we are the consumers of your services, especially for the children, I would say as a country, taken from the 2013 report, we managed to for all the pregnant women to go under testing, especially those who go for ANC, 100%, which is about 23,036 women. Out of those 23,036 women, 38.4% were tested positive. And looking at that again, and also looking on the issues of, to say what support is in place, we really appreciate the prevention of mother-to-child transmission program, because we are seeing now a decrease on children that are born HIV positive. We are talking of about 3% of the children that are born HIV positive. And children that are on treatment as of 2013 are 7,943. Now which I think it's very important now, is to say the women that are coming for ANC, the 100%, is it 100%? Meaning that, do they all access ANC? That's the challenge. Looking at the policies in place, especially for young women that are in school, whereby at the moment, because of policies that are not conducive, that as a young woman being pregnant and you are still kept in school, they end up, like hiding up to the last stage, So that's also another role which we need to, so that we'll make sure that 100% pregnant women access ANC. And two, also the issue of, the custodian of culture, especially the religious group, when they've got in place to say no sex before marriage, and then that young woman who is an active religious in whatever level, but now hiding up to the last stage, then how can we put the custodian of culture, custodian of religion into this program so that they will support their people? So it's very important, again, also to strengthen, as we strengthen other health services, but those stakeholders are very, very, very important in making a difference. Again, when I was also looking at, to say, out of that 100%, but only 89% start prevention of mother-to-child transmission, especially out of the 38%. Then, hence, raise that 11%. It's an issue. One, looking how do the people socialize? Do we take our services to the workplace? Meaning, how are the what can I say? What are policies to support working young women who are pregnant? For instance, what I've discovered in my country is that when you are working in informal setting, paid by an hour, if you go for ANC and then you are 2 hours instead of 8 hours, you will be paid for 6 hours, not the 8 hours. And hence that hinder the prevention. So it's very important that we take our services now and house them where working class is, especially for those informal who are working in big factories. We can house our services for ANC, for family planning, to where women are. So it's very important as we put the strategies in place, but we understand how do the social groups and how do we meet them. And also, what I can also say, another issue is that those children we're talking about, they grow up. They become young adults. Do we also support? What about the stigma? What about the issue of to their colleagues, especially in school? Is there any support, a strong support, for to say in a class of 50 children, 10 of them are on art? What about those days when they are absent from school because they have to refill? What's the stigma behind, Those are the other issues that we must make sure that we link our services with other stakeholders, especially people who are there and people who are also with children. Finally, I will say it's very important that we also strengthen our system so that we run away from defaulters. Without resources in place at facility level, whereby a health worker will just SMS a client to say, you are expected to come on the 15th, but now it's the 17th. Where are you? So without those simple and community-oriented and implementers-oriented and also understanding the social life and also taking on board custodian of certain groups of culture, of religion in place, we will really achieve this. So I'm looking forward that we reduce the, 3% is a lot. It's a lot. Not 0 point something. Born HIV positive, 3%, it's a lot. So with your help, as you are in different corners, please support us so that we implement those programs. I thank you.
Thank you also for your spontaneity in joining the panel unexpectedly on your part. While I think it is 1 o'clock and we were meant to end at 1 o'clock, we started 5 minutes late, so I'm going to just open the floor in case there are one or more questions from the floor. Just 5 minutes, or say maybe 2 questions. I'm not seeing a hand yet. There's 1 and there's 2. So 2 questions, sorry, and there was a third that I missed. If there's short questions and short answers, we'll get in the third and then we'll be able to break for lunch.
Hi, I'll make this short, but I can't guarantee coherence. Madam Ambassador, can I ask you to clarify something? I'm sorry, my name's Donna Rosenfeld from D.C., see? And I was particularly struck by your statement that improving the lives of children living with HIV, the under 5s, is a humanitarian effort rather than because the people treating kids under 5 does not impact the epidemic at that moment. I was really confused by that actually because I can imagine a situation in which raising children living with HIV and the uncertainty of that and the care of that could negatively impact the health, the immunological strength, the happiness of a family, the happiness of a mother, which could then lead to perhaps not prioritizing their own health or whatever. I was just interested in sort of the bracketing off of the physical health of the under 5s as something that did not, that by definition didn't have an impact at that moment, that the under 5s were significant only because in 10 years they would not be under 5s and they'd be sexually active. And I was wondering whether that's perhaps maybe a slightly myopic way of looking at it. I could be wrong, but I was just wondering if you might want to comment on that.
Got it, thanks. That's the first question. Let's take the second one, and if it's also quick, we'll do the third, and then we'll go for the answers. Here we go. Mike is on the move.
Yeah. Just a very quick comment, kindly again. This issue of providing care for pediatrics in pediatric setting, I think having sat through some pediatric clinic for a year and seeing some of the challenges that people face, I am hoping that something much more concrete will come out of this conversation that can put out there, what SIF are suggesting, and I know what EdPath tries to do, is to bring a much more sense of community ownership for caring for pediatrics. Because at the health center, it's not happening as effective as it should. I know healthcare workers who are afraid to even touch children, not because they don't want to, but they're just afraid that maybe the mother might not show up, as we heard. And therefore, what's the point of starting this child on treatment? What is the point? And so you've got all these other, social issues that are coming into the picture. And I'm hoping that we can really begin to bring the community in providing community support.
Very good points, thank you. Which gives us time for the third hand over, just there she is.
Hi, Jennifer Cohn from MSF. Really appreciate this panel, and pediatric HIV is something that we have been concerned about and working on as well. In particularly, we do appreciate kind of bringing the 90-90-90 concept with the cascade that Badara described to pediatric HIV. One of the things that we are most concerned about is the first 90, just the identification of the children. And so this is kind of a question to the open panel, but what do you see are the most important or priority interventions to identify these children, and what are the tools and evidence that we need to support these interventions and prioritizing certain key interventions to just identify the children? Thanks.
Good, thank you very much to the point. Ambassador Birx, you're welcome to comment on the second question, but the first one was directed to you.
Yeah, I get what I was trying to say is this is a moral imperative, and because of that, it needs to be approached that way, and it comes back to the second question about the community piece. Everyone has to believe that this is a moral imperative. When we started PEPFAR, it was because it was a moral imperative. It was started to save lives, a humanitarian effort. It ended up changing the course of the pandemic. And so it's not that that's a choice that we're making. It's saying this is equally a moral imperative for us to move forward now with each of these groups that have been left behind, the children being the most compelling to me because they're the most voiceless in all of this. They're the least, they have the least ability to independently seek care. They're sick and suffering at home. And so I think this is the community piece that I do think has to come into play because of the, I do think that particularly mothers are still highly stigmatized. People still believe that all the infections in Africa spontaneously are occurring in mothers because those are the individuals we ask to come forward for single-dose nevirapine, to give up everything, to take on stigma and discrimination in the village, to lose their household, to lose everything to protect their child. And so I feel very strongly about mothers and protecting mothers now, but I also feel that the communities need to take this on as a moral imperative.
Open it to the panel. Any comments about to the question from MSF, our MSF colleague, Pete?
Yeah, thanks very much, and appreciate the question. I think it's absolutely germane to how we move forward. So thank you for that. I think the issue, first of all, is we've got to get testing at birth. I think that's what we're doing. SIFS has invested 17 million over the last 4 years for a point-of-care nucleic acid diagnostic. We're rolling it out now, in fact, with MSF's help in a number of countries very successfully, and we hope under the new initiative we'll have some of that available. Second point is that we need to take the identification of testing in children out of the HIV/AIDS community singularly. One of the biggest shocks to me, I was in Zimbabwe with Chip and his team earlier in the year. 700 severely acute malnourished children in one cohort in Zimbabwe. 75% of those children undiagnosed HIV/AIDS. Similar studies going on about malaria deaths and diarrhea deaths in some of these high-burden countries. We're not routinely testing children in pediatric wards. We're not routinely testing children in sick child wards. We're not routinely testing children at all points of contact. So I think the identification issue is take the identification out of just the HIV/AIDS programs and mainstream it into the maternal child health and child well-being clinics. I think that's that. Secondly, if we've got new technologies, let's get them to where they're the most effective, and identifying early not only is good for the identification of children, it will reduce those high early mortality figures from those first 6 months.
Minister?
So, I think for Unitaid we're going to have to change our motto to getting the right commodities to the right place at the right time and being at the right product. So again, I think simplification of treatment in particular is something that we're looking for. Even recently in Kenya we had children, all of them HIV positive, all of them on treatment. Those children who were taking one pill thought they were less sick than those who were taking 4. So we really do need to push better treatments for children. So interventions for us will be still very much so on the treatment side, as well as the diagnostic and point-of-care diagnostics, which also MSF is doing for Unitaid at the moment. Thank you.
Thank you, Julius. The Honourable Minister?
I want just to react on how to identify and how to reach children that are HIV positive. I think it's the way I understand her. Really, we need to link our services. Starting from the ANC, we must make sure that there is a consent form which will make us as service provider to do a follow-up. Working mothers, sometimes they send their maids for immunization. So if we can link immunization, link also ANC, and so that when they come for 6 weeks, 14 weeks, 18 weeks, 24, for immunization of other diseases, we must make sure that there is an ongoing testing that is taking place within that period. So if we can link from pregnancy and also immunization exercise, then we'll be able to trust the under 5. And also, some of the children, especially for the working mothers, in certain countries like my country, there's formal and informal daycare centers. If we make sure that we also reach them there, if a child is now taken for informal if we leave forms there, while their mothers, they bring their children, there is also a form to sign for consent. We'll be able to reach the children. So let's use existing strategies and also make sure that we go out, we reach places where children are. And also we mustn't disturb the social way where people, meaning that disturbing, because as I said, in some countries, the issue that the mother would be out of work and then won't be paid. So let's just make our policies, our implementation user-friendly to reach children.
Anya, and then I'll stop because I'm getting the evil eye from...
Yeah, I think a lot of them have been mentioned already. I think it goes back again to that we know what to do, but we don't know how to systematically implement it. And one thing that I didn't hear was, again, talking about having the adult as the entry point. In one of our programs, we have put like a family tree within each of the files so that the service provider is reminded every time again, like, do you have any children? Have they been tested? Because one study showed that 80% of the children of the adults were unknown of their status. So really having these type of systematic reminders of things that we know to do, but we tend to forget, I think might really get us a long way.
Thank you very much, Anya. And with respect to the time frame, I won't do any closing remarks. Thank you for letting us have a few extra minutes. And thank you to the audience for listening to the panelists. Thanks.
Thank you to the panel. And I guess the fact that there were so many questions and comments indicates that this is an area that we're all very keenly interested. We're going to break until 2 o'clock sharp. And please be back from lunch promptly, as Meg Dirty is going to address probably one of the most important issues that emerges from having a clear target now, how we're going to optimize the HIV treatment continuum. Thank you.